Okay, so I think we'll kick off. There's still people joining, but it's 3 minutes past 8, so it's a good time for us to start. So thank you all for joining us this evening for the 5th and final in our Radiotherapy UK Talks series for 2023. My name is Sarah Quinlan and I am the Director of Radiotherapy UK, the only charity in the country advocating specifically for this life-saving yet underfunded treatment. Now is such a crucial time for cancer care and treatment in the UK, as we are living in such a fraught climate of deepening poverty, the cost of living crisis, and war and conflict, that we are at real risk of losing sight of the many lives that can be saved or improved if we get cancer treatment right, through investment in the workforce, equipment, and technology. Our job at Radiotherapy UK is to keep UK cancer treatment in the spotlight no matter what. And one of the ways we can do that is by holding talks like this, celebrating and exploring the incredible science and advancements in radiotherapy as they unfold in real time. It can be so easy to only focus on what's going wrong for cancer patients. So this is our moment to look at what's going right. So in a small change to proceedings, unfortunately, Ben Howard is unable to join us this evening, but he has been very ably replaced by his colleague, Erik Geerlof. So thank you, Erik, so much for joining us at quite short notice. But before I hand over to Erik, I'll just run through some housekeeping. So firstly, just to note that as an independent charity, Radiotherapy UK are, of course, vendor neutral. We are delighted to be focusing on new developments and innovations in the field of radiotherapy, which is the focus of these workforce webinars. So please use the chat function to introduce yourself and for any comments or questions that you have. This is such a good opportunity to engage with each other and with Erik. And after Erik's presentation, we have time set aside for a Q&A session where we will get to as many questions as we can. So please do put your questions in the chat throughout the presentation, and we'll be gathering them throughout and we'll be able to put them to Erik at the end. So we will send up a follow-up email following the webinar with the recording and any other relevant links that are discussed or highlighted throughout. So joined tonight also by Lindsay and by Alison from our team at Radiotherapy UK, who will be helping run the session. Drop them a direct message if you have any questions that you don't want to put into the chat. And now, without any further delay, please welcome Erik Geerlof from Elekta.
Thank you very much, Ms. Chairman, for the introduction. And yeah, as mentioned, my name is Erik Geerlof. I'm not Ben Ewart, as you have seen in the announcement. Unfortunately, Ben had a lot of trouble with his flight coming back from Spain to the UK. And I will talk on Ben's behalf about MR-Guided Radiotherapy, MR-GRT, and a little bit more specifically about MR-Linac. I'm actually trained initially as a diagnostic radiographer and an RTT, so I have been imaging and treating cancer patients myself, like most of you are doing as a healthcare provider. And then let's start with the presentation, but not before I want to give a big thanks to Radiotherapy UK for the opportunity to present as part of the RTUK Talks, New Developments and Innovations series. So we have put a little agenda together, and actually we would like to start with the introduction. What is an MR-Linac? And then we continue with the initial experience from clinical centers. So I have a couple of clinical cases from customers who have already experienced treating with an MR-Linac. And then last but not least, we have some clinical evidence gathering and trials overview. Because it's very important for the community in radiotherapy to get the proof that MR-Linac is at least not doing anything worse than any conventional treatment device, and hopefully we can have the proof how well this device is doing in the community of radiotherapy, which also hopefully has a positive impact on reimbursement, which is still very important. I think we all know that around 65% of the tumors we treat in radiotherapy are soft tissue tumors. And equally, we know that MRI is one of the best image modalities for visualization of high contrast soft tissue. And that makes actually the combination of MRI and LINAC the perfect device for personalized radiotherapy. And then even on board, we have the advantage of onboard biological and functional assessment capabilities. I will briefly talk about that in my next slide, but that's coming actually for free with high field MRI. So let's first have a look at the key attributes of what an MR-Linac is. First of all, we are talking about a high performance external beam linear accelerator. And secondly, we have a magnetic resonance image device. And here in the picture at the right side, you can see in yellow in the middle, basically the MRI scanner. And around the MRI scanner, we have a slip ring device or a device on which the linear accelerator components are mounted. So everything that's outside of the scanner is basically what makes the linear accelerator. Over here on the couch, you see the anterior part of the body coil, and built in the scanner itself at the posterior part of the patient, basically built in is the posterior part of the body coil. Here's some patient positioning devices, and that basically makes the machine. But then on top of the hardware, we also need software solutions to enable online adaptive treatments. And I think one of the big differentiators, if you compare to conventional radiotherapy, is that treatment planning suddenly is moving away from a standalone separate treatment planning department to the console where the radiographers or other healthcare providers work to treat the patient. Because while the patient is on the treatment couch in treatment position, we are going to online adapt the treatment plan. Then we need, obviously, where the LINAC and the MR scanner are coming together, no interference between these subsystems. So there should be no interference between the MR scanner and the LINAC. And I think that was one of the biggest challenges for everybody involved developing an MR-Linac, because we all know that the two devices, a Linac with high energy and an MRI scanner with a high field strength, basically don't work together. So they had to come up with a lot of technical physics solutions to make that happen. Another thing for the treatment machine being very important is well tolerated by patients, because patients will be relatively long on the treatment device per treatment fraction. So it should be highly tolerated, and Elekta did a lot of modifications to make that more tolerated by the patients. And then streamlined for the operators during the treatment delivery, because it is quite stressful in the beginning while the patient is on the treatment couch to modify, to adapt a treatment plan. You want to do that as quickly as possible, and the only way to do that is when the systems are working in a streamlined way very nicely together. So why did different companies come up with MR-guided radiotherapy? Why is the community of radiotherapy at the moment so much focusing on MR guidance? I think we all know that we, in a conventional fashion, work in radiotherapy with high perfractionated treatment techniques. And we did this because we were using relative large margins to make sure that we are covering the tumor and applying the total dose to the tumor. But at the same time, to avoid toxicity or at least too much risk in organ at risk, we did introduce this high perfractionation treatment modality. But we also know that if you look at efficiency of radiotherapy departments, if you look at efficacy of the dose to the tumor, and hypofractionated fashion is actually much more interesting. But the only way to do hypofractionated treatments where we have a very high fraction doses and we have very little chance to compensate for setup errors in between fractions, We have to be able to very clearly see what we are treating. So that basically means we need to see the tumor, but equally, we also need to see the organs at risk very clearly. And I always tell people that I think that the main core business for MR-Linac is not so much the tumor, because many treatment devices can apply doses in the tumor, but it is more focusing on the organ at risk, because the lower we keep the dose in these organs at risk, the more we are able to increase dose in the tumor. And that's what basically hypofractionation is all about. Then obviously being able to adapt to the treatment in real time, because when we see any small setup deviation, we need to be able to compensate for it. And that also has to do with the fact that we have limited number of treatment fractions. And if you want to minimize the dose in the organ at risk even more, then focusing on motion is a very important one. And when you acquire very crispy, clear MR images, then you can easily do, or much more easily do, a motion monitoring. And that's what we also have included in this MR-Linac treatment modality. And then last but not least, assessment of dose response. So with help of MRI, and that's basically coming for free on top of anatomical image acquisition, we also can do some biological assessment, which basically means that we acquire specific sequences from the MRI to assess those images on biological response. A little bit more focusing on adaptive radiotherapy, because I think in the community of radiotherapy, many people are talking about adaptive radiotherapy, but I think we are not always aligned and speaking about the same thing. I'm very sorry for being having quite a busy slide, but what we try to show here in this graph is actually the value of the different adaptive paradigms, and also the technical development over time where we are now. And I think we all can agree that an anatomy adaptive paradigm is one where we have quite some experience now. And this actually means that we try to shrink the cumulative PTV by adapting to changes in the tumor shape and its position. And that's what you do when you acquire anatomical images. You look at it and you make a decision based on those images. But another level of the adaptive paradigm is actually dose adaptive. And in the dose adaptive, the dose to the tumor, we all know, is determined by the constraint to the adjacent normal tissue. So actually that means, for example, that over here on day 1, part of the target will receive only 6 gray because it is very close to the adjacent normal tissue. But on day 2, where the target is much further away from the normal tissue, we can increase the dose for the total target to 8 gray. So we are not only looking at, are we positioning the tumor and organ at risk the proper way, but also we are making changes on the dose we apply for a certain treatment fraction. And then in another treatment fraction, we have to obviously compensate for that again. Or we even are able to increase the prescribed total dose because we have never met the constraint of the organ at risk dose. And then last but not least, we also have the response adaptive. And actually the response adaptive means that any change to the pre-RT, CTV or organ at risk or the delivered prescription is based on intra-course biomarker assessment. And in the next slide, I can give you a little bit more example about how this looks like. Again, a little bit a busy slide, but in MRI, on MR-Linac, that allows for on-treatment imaging. That's what we all know. But on top of the online on-treatment imaging, we also can apply a diffusion-weighted imaging, or in other words, an abbreviation of DWI. And I think we have more heard about that. And the DWI sequences can measure biological response. Now, if you look here at the graph at the left side, then actually we see an ADC value, the median apparent diffusion coefficient value for the tumor that is treated over here. And we see, if we make a comparison between fraction 1 and fraction 30, so this is definitely a hyperfractionated treatment fraction, we see that there is a nice increase of ADC value over time. And that basically is a good sign, because that means that where we did measure tumor in the beginning, we measure normal tissue again in the third fraction. And equally, if we would measure an ADC for healthy tissue, the surrounding organs at risk, we see that there is no difference, which again is a good sign, because what we had as an ADC value, which was very good, we want to keep that value obviously over time for the organ at risk, because we do not want to apply any toxicity or anything like that in the organ at risk. So actually the study that was related to these pictures is actually showing the proof that DWI can be used on the MR-Linac for biological measurements. Now, focusing first a little bit more on the why we are using MRI in radiotherapy as a image modality together with the Linac. I think this slide is quite nicely showing that if you want to look at a oligometastatic disease on a CT, then it is very hard to find it over here. When you look at it on a commune CT, which is your image, the standard image modality during radiation, it's very difficult to see it even there. So that's even more hard to see. But when you are using MRI, either on a MR sim or on an MR-Linac, it is much more obvious to see the oligomet. And when you see the oligomet so clear, because it's very crispy, visible on the MRI, then you also can tighten your margins and increase the dose, and that makes it much easier to treat such a tumor. An example here is that we have had many customers starting with prostate and oligomets, and actually it was a little bit a surprise for Elekta that oligomet was taken off so well. So I think it's at the moment about the second number of patients treated on the Unity. And here we have an example of a patient who had a radical prostatectomy and represented two enlarged common iliac nodes in the pelvic around L5. You see very small volumes of these oligomets with a maximum diameter of 7 millimeters, which is actually quite large, because I think nowadays when PET PSMA is helping to diagnose oligomets, then the average size is between 2 and 3 millimeters. So you can imagine very hard to see on a CT and even harder to see on a commune CT, but still very good to see on MRI. And these very small tumors require precise targeting and visualization. So now we have the very precise visualization, but obviously the targeting for the dose should be very accurate as well. And what you can see here in this example is that this patient was treated with 30 gray in 3 fractions, so 10 gray per fraction, almost ultra hypofractionated. In a stereotactic IMRT treatment modality, it was using agility, but I think the most important thing here to say is that Elekta is making use of multi-leaf collimators, and that's what many vendors are doing. And obviously you want to have very small leaf width, but you can do that either by using a very small physical leaf width, or you use a virtual leaf where Elekta, for example, is using the jaw, which is perpendicular to the direction of the leaf. And that helps to make the leaf width even smaller, very close to 1 millimeter. And that is what you need to be able to get these kind of dose distributions, which are almost SBRT-like or SBRT-like. And that allows them to get a very steep modulation and dose gradients and to protect, obviously, the organs at risk, which are very close. Then another example on prostate SBRT, and this is actually a clinical example from the customer from University Medical Center in Utrecht. This started actually with the question about customers having, or patients having problems with erectile dysfunction. And basically the question was, how can we reduce this erectile dysfunction? And we all know whatever you do on a prostate patient, patients will always suffer on erectile dysfunction, whether you have wait and see as a kind of treatment modality, or you do surgery, or you do radiotherapy. Patients will always suffer on this. So it was very interesting to start using the MR-Linac for prostate treatments and focus a lot on the organs which are responsible for this erectile dysfunction. And that's actually, those organs are very much the internal pudendal arteries and the neurovascular bundles. Those are the two main responsible organs at risk which cause this erectile dysfunction. So what was done in the hospital was each treatment fraction when the prostate was treated, also these two organs at risk were delineated, which you can very clearly see here in the image. And the dose was tracked very well for each treatment fraction, and that dose must have been below a certain constraint, a certain dose level. And then the idea is, because the erectile is now closed, but they are now reviewing all the data, the idea is that the erectile dysfunction will reduce because of the dose that is reduced on these highly critical organs at risk. And we all think that we know that many patients with prostate cancer are still relative young patients. And we all know when we can control the erectile dysfunction, then not only the patient, but also the spouse will be very happy. So that's a real good challenge and real good tumor site for us to work on together with our customers. Pancreatic cancer, obviously a very difficult cancer to treat with radiation therapy. It has been done on conventional Linacs in the past, I think a very limited number of times, obviously related to the highly critical surrounding organ at risk. And that makes it that radiotherapy is very difficult on pancreas. But since we can so clearly see the pancreas, but also the surrounding healthy tissue, we think that the MR-Linac, and that's at least what our customers have experienced, is an excellent treatment modality to treat pancreas cancers. The same, by the way, would count for primary livers and secondary livers. Being in the upper abdomen, very difficult because of the surrounding organs at risk, but because we can see it so clear on the MRI, it is very much used on MR-Linacs. And what you can see here is that this was actually a case treated in Memorial Sloan Kettering, and they did that for a group of patients, and 86% of these patients did not experience any acute grade 2 or higher toxicity, which is very nice, because actually this was also done in hypofractionated treatment, 5 times 10 gray. And there were actually no grade more than 3 acute toxicities related to the ablative dose to the pancreas. So that was a very nice outcome. And then we have another example from University Medical Center. And the reason why I want to show you this example is because on top of the very crispy images that we have nowadays with MR-Linac, because of the MRI, we have also now motion management. I briefly spoke about that in the beginning. We actually, within Elekta, we call that comprehensive motion management, but it basically means that we can acquire images during the delivery of the dose, and we do this in 2 planes. And while we acquire these images, we are tracking quantitatively the position of the tumor over time. So what you can see here in this example is that we are tracking the tumor, which is presented in red. It's actually the GTV. And then we have on top of the GTV, we have a PTV, which is acting as the gating envelope. So in other words, the GTV should not exceed the position of the PTV. And you can set up a certain tolerance for that level of what you allow to exceed or not. In this case, the customer decided for 95%. So that basically means that 95% of the GTV should be within the PTV. If that value exceeds, then the beam automatically will be turned off. And that is presented in this graph here below with help of these orange colors. So what we see here is actually, it's very, very tiny, I realize, but we have here the 3 directions in which we quantitatively detect the location of the organs. during the dose delivery. And each time when this 95% coverage, this tolerance is exceeded, the linear accelerator will turn off, which is presented with this orange color. So each time when we see this turning orange, we also see that in the graph later on, then the beam is very quickly turned off. And while the 95% is coverage is covered again, the beam will be turned on again, and this will all be done automatically. The reason why MR-Linac was decided for this oligoprogressive metastatic melanoma is that it was very close to the left renal vein, which is obviously a highly critical organ, but also because it was located in the upper abdomen, and it would very hardly be visible on chromium CT. And the location of the target is obviously influenced by a lot of respiratory motion. That's what you have with upper abdominal tumors. So having the capability of motion management and gating makes it very attractive to do this on the MR-Linac. Yeah, I think this is again quite a busy slide to say something about workflow, and I think particularly for the RTTs this is a very interesting one. When we started with MR-Linac in 2018, I think expectation was that on the Linac a radiation oncologist and maybe a physicist would always be required as part of the team to drive the complete workflow. But what we have learned over time is in countries where RTTs are, I would say, relative highly educated RTTs, at least they have understanding, education of dosimetry, contouring, fusion of images. We have seen that these RTTs are very well capable to drive for certain tumor sites the complete workflow themselves. So we have in a couple of countries many customers where they treat with MR-Linac cancer patients on the MR-Linac without any interference of radiation oncologist or a physicist. And that basically means that plan adaptation, the contouring, the delineation of these organs and the organs at risk, the tumor and the organs at risk, but also making a decision on the optimized treatment plan, approving the plan and continue the treatment. This is all done by RTTs. And my experience is when I talk to RTTs who are doing this, that they are highly motivated to treat with this machine in this new way nowadays, because for them there is much more responsibility in the dose delivery itself, and that makes them feel very good, very motivated. So I think for RTTs, very nice. There have been a couple of studies done, and this is a reference to one of the studies, I think, coming from the UK, where a comparison was done in terms of accuracy of contouring, delineation of the tumor, but also organ at risk. And I think the outcome was very, very positive. So that basically means that there was hardly difference between the RTTs and the radiation oncologist. I know the outcome from a Dutch study was that the accuracy of the RTTs was even better than from the radiation oncologist. RTTs always had good reasons why this was the case, but anyways, it proves that the complete workflow can be done by RTTs, and that for certain tumors, involvement of radiation oncologists is not necessarily required, which does not mean that for specific and very difficult to treat cancers, radiation oncologists obviously have to be at the treatment machine. MR-Linac Consortium, we decided that if you come up with such a new treatment modality where you really try to challenge the status quo of radiotherapy, you as a vendor, you cannot do this on your own. So basically you need a team of customers who work together to make this happen. And that is why we started with a consortium of customers who purchase this equipment and work together. And as examples, we have, for example, 10 tumor site groups working together to develop basically treatments per tumor site group. Then we have focus groups where these groups are focusing on various technical matters. like motion management, like dose accumulation, like health policy. So those are examples of what the focus group is doing. And also we have technical working groups, but they are working more on, like new ideas, things that we have to work on for the future and make them happen and see if it would be worthwhile to explore on an MR-Linac. Like, for example, MR biomarkers and also cardiac ablation are things that they are exploring as a group together and see what it would mean for MR-Linac and for the patients treated on an MR-Linac. Now, some of these customers who also treat on or also part of the consortium are also part of Momentum. And Momentum is actually a very large database with information of patients treated in an MR-Linac. We are very excited and proud that we have something like this, a Momentum registry of images and data and outcome of patients, because it is a global database and it contains data belonging to patient treatments, which are done in more or less the same way all over the globe. So all over the globe, customers are working together to treat those patients in exactly the same way. And that means that we have now already more than 4,500 patients recruited in this database. 14 institutions are participating. And yeah, it is fantastic that if you want to explore anything and see if a new technique is doing well, then within a very relative short time, we have all the data collected and available to do statistical analysis or whatever we need to do with the data to say something about this. So that's a very interesting way to get this information. And the fact that this is a global initiative, yeah, we think very special and we think quite unique for this in healthcare. Obviously, many of the patients which are treated in this Momentum, sitting in the Momentum database, are based on trials. There are many trials going on, and that's what we need, because we need to prove, again, as I said in the beginning, that MR-Linac is at least not doing anything worse than a conventional treatment device. But we have already so much proof how well MR-Linac is doing and how great outcome is. Many publications are done. And you see here that there are many trials going on. The length of the curve here basically means the time that is related to such a trial. So here we have stage 2 to A to B and stage 3 trials for different diseases going on. And yeah, this is actually outcome of the use of Elekta Unity and also of Uray MR-Radian. So many trials at the moment going on, and many publications have already been done based on the collection of clinical data. And actually all those outcomes are very promising and positive. So that's a very good thing. Prostate cancer trial is one of the most interesting one, because of the number of patients that we have used coming from the Momentum database, 425, which is an enormous amount. We've seen that all these patients were treated with 5 times 7.25 grays, so all in a hyperfractionated fashion, and then a follow-up in 12 months. Very nice. If you can look up this study yourself, but basically here we did GU and GI toxicity measurements, and this is the one written by Teunissen, so that's the one coming from the Unity, and this was the one coming from the MR-Radian, and it's very nice to see the difference between those values as well. But a huge improvement, at least if we compare to a Chromium CT, which was done on Chromium CT linear accelerator. And then a lot of work at the moment is done as part of the consortium as well on biology-guided radiotherapy. I told you in the beginning about the acquisition that we can do of diffusion-weighted imaging, and then we apply ADC maps, which says something about biological response. So there is also this biological biomarker consortium looking at, as a work group, looking at how to do this. Already more than 25 peer-reviewed publications done Yeah, and again, very interesting to see for all those different tumor sites and the different publications that are already done, how helpful this will be in radiotherapy. Obviously, clinically, no decisions are made, I think, based on the biological response measurements, but at least something that customers can start looking into, collecting all the data, and then what they can do with this. Then coming to the end of my presentation. So in summary, I hope that I've shown you how MR-Linac is helping to address the challenges that we have in radiotherapy today, with a machine that is really challenging the status quo of radiotherapy. And it helps clinicians to visualize, obviously, soft tissue, with the main reason to reduce PTV and ITV margins and improve treatment delivery, and reduce the total treatment times and fractions by introducing hypofractionation. It very clearly helps to track and manage the motion in all directions, which will eventually help to spare the organs at risk and toxicity in the organ at risk, and improve the overall local control. And this allows to continuously adapt and optimize our plan based on the new geometric, but also the dosimetric information that has been observed, and obviously in the long run, not only the geometric and dosimetric information, but also based on the biological response, because that's an addition we get for free with high field MRI. And that's what I wanted to present for today. And then here the email address of Ben, in case you, even after the questions and answers, still have some questions left for Ben.
Thank you so much, Erik. That was really, really interesting. And we've got lots of questions coming through from you through the chat function. So I'm going to hand over to Lindsay, and she's going to go through some questions.
I am indeed. Hi. So, sorry, I'm just trying to get. So the first question is, what are the precautions taken to use the immobilization devices, especially the metallic-based ones? And then also in case of patients who are not suitable for MRI, like having pacemakers or prosthetic metallic objects?
Yeah, so maybe for the mobilization devices, we are coming with, so the machine is actually coming with dedicated MRI compatible immobilization devices. We call them patient positioning devices, PPDs. They are actually coming in two sets, one obviously for the MR-Linac itself, but also one set for your simulator, which can be a CT simulator or an MRI simulator. And if you want to have more of these sets, then obviously they are available in option. So we really want to encourage all our customers to use these MRI compatible positioning devices, which does not mean that certain customers also have their own stuff coming from either in-house developments or coming from other companies. As long as they are MRI safe, then they can be used. The other question about patients that are not eligible for MR-Linac. First of all, I have to say that experience from many patients is that they are kind of almost less scared for this device than for a conventional Linac, because most patients have already gone through MRI for their diagnosis. So they understand the device, they know the device. We have a bore of 70 centimeter width, and it is a relative short bore, which is very helpful for the patient, because they somehow, when they are on the couch and the couch is going into the bore, they already can kind of see the end of the tunnel. So that's very nice for them. And in terms of metal pacemakers, nowadays, many pacemakers are already MRI compatible, but there are special teams then around. I've seen a couple of pacemaker patients done on an MR-Linac. And first of all, there is a lot of quality control, quality measurements already done prior to treating a first pacemaker patient on the MR-Linac. But then when the patient is there and obviously having an MRI compatible pacemaker, Then there is most of the time a team there from cardiology, and they do some measurements, and most of the time it is totally fine. Yeah. And for the prostate, I think there was also a question when there is like metal, maybe a seed or anything in the prostate. I don't know exactly where the question was coming from, but when it is small pieces, then it is not so much a problem. But yeah, of course, always something that we have to look into, and that is why every treatment fraction again starts with a list of questions to see if anything changed on the patient while the patient is already started the treatment. But when the patient is a very first treatment fraction patients, then of course you go through that list and ask what might be making the customer, the patient, ineligible for MR-Linac.
Great, thank you. There's another one here saying, is there any difference between using cone beam guided online adaptive radiotherapy and MR-guided online adaptive radiotherapy? And I think you sort of touched on that a little bit in one of your slides that came on a bit later.
Yeah.
I think the answer to that is yes.
I think it's a very interesting question, because I have to say that in my opinion, I believe the introduction of online adaptive radiotherapy is much bigger than whether you make a decision for cone beam or MRI. The fact that you bring the treatment planning system from a standalone treatment planning department to the linear accelerator, where the patient is in treatment position on the treatment couch, so you have limited time to adapt your plan. And then again, I touched based on it when I was talking about the software and making that streamlined, particularly the integration of the different components. When that all works well, then still it's quite stressful in the beginning to adapt the plan while the patient is on the treatment couch, because you know any minute you add to that time to adapt the plan is maybe new motion or introducing a new error. So that's very contradictory to each other. So I think introduction of online adaptive treatment modality is the biggest step. And then whether you do this with cone beam CT or with MRI, I hear from RTTs who are used to work with both devices. What is very nice on MRI is that the image quality is so crisp and clear in comparison with cone beam CT that if you have to do the delineation as a RTT yourself, as I spoke about RTT-only workflows, when an RTT has to judge about organ at risk, where's the border, where is another organ coming in, it's on an MRI so easy to see, and you always have the MRI from the original treatment plan next to you, so it's much easier to do it.
So do you have quite a lot of outcomes data that show this sort of reduced side effects in a lot of the sites? So like how much long-term data have we got at the moment?
Yeah, that's the difficulty, I would say, in radiotherapy. I mean, for prostate, we have now, what I showed you, the 425 patients, but that's still relative early. For these type of patients, we might have to wait another 5 years to say something more decent. We have very good data about pancreas, and of course these patients have more or less a relative short survival time. So the pancreas, it is a little bit easier. And then I think studies also done by Vuray and Meridian customers have proven that overall survival can increase to almost double the time without any increased toxicity. But yeah, that would be good to look into these papers. These articles are definitely available, and you can read there about these outcomes. Yeah.
Has the MR-Linac been used for much gynae work? I think you had cervix on one of the slides there. Is there any other areas that
I think used? Yeah, at the moment I think the two systems available are having some limitation in the field length. That is what I know why customers are looking into using the MR-Linac for cervix, for example, but sometimes your field length need to be a little bit longer, and then that makes it difficult. But at the other hand, I also know from UMC Utrecht, for example, where they have done cervix, a lot of experience doing this with brachytherapy. Sometimes patients cannot handle brachytherapy, and then they are very happy that still they can do them on the MR-Linac. So it depends very much on the field length, but if the field length can be handled, if that's long enough, then definitely MR-Linac is a very good treatment modality and also used by many customers.
The plan of the patient and the contouring is done online while the patient is on the couch. However, are there a real-time monitoring at the same time of the treatment delivery, like real-time adaptive when you're delivering?
Yeah, always. And on top of that, we have not been discussing workflows. Elekta is actually supporting different workflows where you just look at the location of the tumor, and that's basically it. And you compensate with the virtual couch shift. But some of our customers, on top of the constant motion monitoring while the plan is online adapted, some customers also do a quick what we call adapt to position, which is kind of COM-MCT like virtual couch shift workflow. After the plan has been adapted, that requires another 2 minutes, but then you are very safe to continue starting the treatment, because then you have done another acquisition of a 3D MRI. You have done a quick check on any translational errors, and that takes you only 2 minutes more. And there are hospitals where they are now down to margins like 2 millimeters. So in University Medical Center in Utah, for example, their prostate treatment has a margin between 2, sometimes 3 millimeters, but 2 millimeters is more the average. And that's what you can do, because you do adapt to the plan. But after the plan adaptation has been done, just before it is finished, you acquire a new 3D MRI data set to do a quick adaptive position check. And then when everything is fine, you start the treatment. Yeah.
Next one is, you mentioned adapt real time to account for intrafractional changes, and that will help in the daily plan optimization. But what do you mean by plan optimization?
Adapt the plan and plan optimization, I think, to make the plan more personalized for that particular patient.
Yeah. Scott, is the Momentum database only for Elekta, or are all companies who use MR-Linac entering data into it?
Yeah, no, that's only for Elekta. Yeah, that's for customers, not for all customers, but for customers who are at least part of the consortium, and some of them are also part of the Momentum study.
Yeah. What's the up?
If I'm an Elekta customer, then it's very easy to get access when you have an MR-Linac from Elekta.
What's the uptake like at the moment in other countries? How many MR-Linacs are there out there, say in Europe at the moment? Do you know?
So we have, I mean, globally there are MR-Linacs in general. So if including competition, way more than 200 systems are sold. I think we are now in an installation of Elekta's, I think around 65 who should go clinical very rapidly. I think just a little bit below 60 are clinically now, and I think there are like 8 machines under installation, being very close to going live. And the uptake of MR-Linac, well, I mean, I'm from the Netherlands and I'm outside of the UK. We have at the moment 10 Elekta MR-Linacs in the Netherlands sold, and competition had 3 machines. So we had in a country like the Netherlands 13 MR-Linacs. And then I have to say that there is one hospital where they have 2 MR-Linacs, and there is another hospital where they have 3 MR-Linacs. And that's just in the Netherlands. But we see now more and more countries that it starts to become more common to have not only one MR-Linac at the department, but to have even more. Also, the interesting thing is that we have a very nice spread of different customers. So obviously MR-Linac started with university hospitals. They had the resources, the people, the money, the knowledge to introduce these type of new treatment modalities. But we see there is a very nice uptake by even private hospitals in countries like Switzerland or countries like Germany. Private hospitals, also in the UK, private hospitals who want to, follow with this new treatment modality and also be able to treat their patients the best way. And that's very, I think, a very good development that we see happening.
Because of the magnet and stuff, what are the biggest issues when considering sort of an installation base? Are there sort of bigger other things to consider with regards to the magnet than just installing a regular Linac?
Yeah, so what we have to take into account is, I mean, it is related to the magnet, and maybe that is meant, but just to mention that the installation of the MR-Linac is not only about the room where the MR-Linac, the bunker where the MR-Linac is going to be installed. You always have to keep in mind what is the surrounding equipment that might interfere the MR-Linac, or subsequently the MR-Linac interfere the equipment around. So for example, elevators, if you have elevators next door, which are causing a lot of interference, then yeah, this is something you have to be aware of when you are considering using that bunker as an MR-Linac bunker. If you are very close to the outside where there is a street where ambulances are driving and passing by the bunker wall, you have to be aware of that. But that is stuff that we never measure afterwards. We always do this in advance. So we would never ever sell an MR-Linac before we have measured, for example, interference in that in that room that you have in mind to install such an MR-Linac. So it requires more thinking about the surrounding of the bunker rather than just only the bunker.
Great, thanks so much, Erik. I think we probably just have time for one last question because it's been so fascinating. The time has completely flown by tonight. But there's just a question about what kind of prep is required for patients, bladder, bowel, drinking water, if any.
Yeah, what preparation we do for the customers do for the patients?
Yeah.
Yeah, I think the customers are a little bit more relaxed with their patients in terms of bladder filling, because they know the patients are for longer time on the treatment couch. So if you ask a patient to come with a completely filled bladder and then the patient has to be on the treatment couch for, let's say, 30 minutes, then you might run into some trouble. So they are a little bit more relaxed. At the same time, we can allow doing this because we are not positioning the patient based on external markers, but we are positioning the patient based on the anatomy that we see real time with help of the MR images. So even if we know that because of a not completely filled bladder, organs at risk might be close to the tumor, whatever, then you can compensate and adapt your treatment plan for this. So it is also less critical because you do online adapt your plan.
Okay. So I think, Lindsay, that's probably the questions that'll come through. Thanks for that, Lindsay. And thank you so much, Erik. Thanks for your time and for coming on last minute because of Ben's difficulties. We so appreciate that. And it's really great to get an opportunity to speak with you like this tonight, through the engagement from the chat and just from hearing your presentation. It's obviously a subject you're so immersed in, and we're so appreciative of your time and expertise. So thank you so much.
And thank you again on behalf of Ben and Elekta for being able to present here.
Thank you. And just before everyone goes off to the rest of your evening, just a few minutes for some updates. You'll also see in the chat that we're just asking you to share your one takeaway from tonight. This is really important to us. It gives us really important feedback. So if you could do that, that would be fantastic. A few updates. We'll be heading to London from November 13th for London Global Cancer Week, where we're co-hosting an event with the Global Coalition for Radiotherapy. and helping launch a brand new cancer plan written by the Lancet and co-authored by our chair, Professor Pat Price. The government has unfortunately moved away from cancer plans in the last few years, and yet they are so crucial to making sure patients have fair access to treatment. So we are working on writing our own within the radiotherapy vision with partners, and also within this Lancet piece supporting that, because we really need to drive much needed change in how cancer plans are developed, implemented, and the investment that's required to improve outcomes for patients. So we'll be having lots of socials over that week, so please follow us on the socials. And if anybody would like to attend the Global Coalition event with ourselves, do reach out and we can arrange an invite for you. Also, just to let you know that Miles for Radiotherapy raised more than £17,000 this year. Many of you here tonight were part of that, so a huge thank you to us. And a reminder that next year's event is going to include an in-person event, and we'd love to see some more of you there. So stay tuned for a newsletter on our socials, and more on that in spring 2024, which seems far away, but definitely actually isn't. And we have World Radiography Day fast approaching, November the 8th, and we just wanted to spotlight that one of our ambassadors from our Ambassadors Network, Joe McNamara, will be collecting a Radiographer of the Year award. They've got a write-up about that on our website, and we're really excited for Joe and just feel so lucky to have her as part of our network, joining with all the other fantastic Radiotherapy UK ambassadors, and a big congratulations to her. And a reminder, we are going to be back in 2024 with another series of Radiotherapy UK talks with a focus on patient experience. So the last thing really is from us, Christmas is fast approaching, even though it's not Halloween yet. Christmas is still around the corner, and we're going to be launching our Christmas appeal on November 21st. We are asking patients, professionals, and our supporters to organise Christmas jumper coffee morning in memory of Kelly Smith. You may know already that Kelly died far too soon. She was only aged 31 from bowel cancer, and that happened because her treatment was stopped due to the pandemic. Her parents went on very bravely to co-found the Catch Up with Cancer campaign with Pat. We are now more than 3 years on from Kelly's untimely death, and although the pandemic is over, patients waiting for treatment is an increasingly common and disturbing norm. All of the funds raised from these coffee mornings will support our vocal work in calling for timely treatment for patients, and your help would be so appreciated. When we follow up after this event, we'll include a link if this is something you can support us with. So thank you all so much for coming and engaging tonight, and to everybody who's participated, both speaker-wise and participants and attendees through our first ever Radiotherapy UK Talks series. We've really enjoyed delivering it. We hope you've enjoyed it as well. And yeah, that's really it from us for 2023 for the Radiotherapy UK Talks. So thank you all and good night. And I hope you enjoy the rest of your evening. Thank you.